Good day, global citizens. Welcome to another episode of Fajembola'S Opinion. This is a platform where research meets understanding and legacy. For the past 12 months, we've talked about HIV repeatedly, and an aspect of HIV where we've really discussed is PrEP and how it comes about. I know people have heard of PrEP, people outside the field of health. I would say more statistics know what PrEP is, because people who use it, to my own understanding, mostly are people in the field of health. They are the ones who know about it, how it's used, and who have easy access to it compared to people outside health facilities. So today we are going to look at PrEP, everything we need to know about PrEP, and how PrEP can be used to improve our prognosis to improve the prognosis of an individual who suspects that they might get infected with HIV. So before we dive into the discussion, let's quickly welcome our guests. Mr. Ifeanyi Ngwoke, how are you doing?
Thank you so much for this opportunity to talk about this subject. I think I've been in this space for some time now, so I really want to talk about this PrEP.
Okay, thank you so much. I've known Mr. Ifeanyi for a while, and if someone had told me we are going to discuss like this, I'll be like, how possible is it? What's the probability? But it's happening now, and I'm glad. I'm glad to learn from you. Aside the social media posts, the educated social media posts, I want to learn directly from you. So, and I'm sure global citizens will learn also immensely and positively from you. Let's quickly go through the profile of Mr. Ifeanyi Ngwoke. So, Mr. Ifeanyi is a public health researcher and infectious disease specialist from Nigeria. He holds a Bachelor in Medical Laboratory Science and Master of Science in Infection Prevention and Control, and is completing his Postgraduate Diploma in One Health at the University of Edinburgh as a Mastercard Foundation Scholar. He currently works as a Monitoring, Evaluation and Research Officer at YouthRISE Nigeria, where he manages evidence systems for HIV and harm reduction programs. His research spans HIV prevention, emerging infectious diseases, and One Health in Africa, with 9 peer-reviewed publications to his name. He's also founding IOHRE, the interface of the One Health Research and Engagement, an Africa-based research and policy institution focused on infectious diseases and climate health evidence for African health programs. So before we dive into the discussion, let's see what global citizens are saying about PrEP. The first is from JJ Chibuzo, where he is saying, if your partner is HIV positive and undetectable, can they still give you HIV? Most people will say yes, but the answers have changed in 2026, not the version you knew years ago. So he created a thread on PrEP and to enlighten global citizens about HIV. So the second tweet is from HIV Medicine Association, where they are saying PrEP use continues to grow in the United States, but the increase from 2024 to 2025 was the smallest annual gain in the past 5 years. Expanding access to HIV prevention services is critical to ending the HIV epidemic. The last is from Dr. Gillis Indayisaba, where he's saying, honored to witness today the launch of long-acting injectable PrEP by the Ministry of Health of Cameroon, a significant advancement in the national HIV prevention response. At EGPAF Cameroon, we are committed to working alongside the Ministry of Health to support successful implementation. So basically, those are three. We usually look at 3 tweets for every discussion. So there is a lot of work that has been done that and people are doing currently on PrEP, and research and advances in HIV includes PrEP formulations to help patients. So now let's dive into the discussion, Mr. Ifeanyi. We are looking at PrEP, and you are a researcher. This is your home. I would not say HIV is your home because of how people perceive it. This is your field, like it's your comfortable place. So what should we
Yeah.
know, Mr. Ifeanyi, about the history of PrEP?
So, well, PrEP doesn't have a very, very old history. So it's not as old as HIV itself, right? So the HIV epidemic started in the 1980s, and then people were dying almost every day. And everything was about behavioral prevention. That was the primary conversation regarding HIV, behavioral prevention. So condoms, use condoms. In fact, from when we were children, those days, I think in primary school then you always hear things like, at least prep. When I was in primary, I left primary school in 2006, so prep was not even there. So I know the conversation then has always been abstain, ABC, be faithful, and then use condom. So everything was behavioral, right? But then the trend of HIV began to change with those behavioral advocacy. The new infections in the general population was a little bit declining or was slow in progression. But in a group we call key populations, that's people who the behavioral advocacy and the behavioral solution was not as effective as it is for this particular set of persons. So we're talking about like persons who use drugs because of who inject drugs, persons who do commercial sex work, men who sleep with men, and that population, that group, even young women, with all the stigma that were attached to using condoms, buying condoms, and all of that. So, and then at that time, too, there was an intersection within that period with the HIV cure itself. So, because some of the drugs that are used for PrEP, some persons also use, there are also some of the formulations that are similar to the ones that are used for ART. So, eventually, research kept on going, and around, I think, 2010, there was a particular trial. I think we call it the PrEP X trial that was done in 2010. So that was when we got the first formulation, that's tenofovir, and it was approved in 2012 by the U.S. Food and Drug Administration for use. So that's undergone clinical trials for efficiency, for safety, and then it passed. And then we had the oral PrEP. So that's the history about how PrEP came about since then. 2010 was the major time when that trial was done, and 2012 was when the first formulation was approved for use. So I think that's just some very background to PrEP history. Thank you.
Okay, thank you so much. You've given us an overview of the history of PrEP, and we have an idea of what PrEP is. But now, many people are abusing PrEP. Many people don't even feel they're eligible for PrEP. So when should an individual use PrEP?
So PrEP is pre-exposure prophylaxis. That's the meaning of PrEP for some of our listeners. So I have to remind myself that I'm not just talking to you, right? So it's pre-exposure. It's pre-exposure. So meaning that before someone is even exposed, PrEP is a prevention. That we have HIV prevention, we have HIV treatment, we have HIV testing. So in the way we do the cascade, the United Nations AIDS program cascade, we always have 95, 95, 95. So we are saying everybody, 95 of we should have like 95 of the population should be tested. 95% of those who have been tested and confirmed positive should be on ART, that they should be on treatment, and 95% of those who are on treatment should have viral suppression. So you see that first 95, that testing that we do, everybody should, at 95% of everybody that is at risk of HIV should be tested, which is almost the entire general population. So testing is one prevention strategy for HIV. There are so testing, we are testing people as prevention. It's a prevention strategy for HIV too. But then we also have condoms, the behavioral part that I just spoke about. Then we now have PrEP. So PrEP is for prevention. PrEP is for prevention. But now PrEP is usually indicated for those who have a very substantial, significant risk of coming down with HIV, of contracting HIV. That's why the PrEP program is always targeted towards these people we call priority populations or key populations, because these are people whose behavior predispose them to significant risks to HIV. Also, sometimes even beyond their behavior, demography. For example, if I say men who sleep with men, people who inject drugs, female sex workers, we need to now start talking about adolescent girls and young women. Why? The question is why? Because at this age, people want to test. They want to. The youthful exuberance is there for them to actually try things and all of that. So because of that, that issue, coupled with other challenges with accessing condoms, other challenges with cultural issues, and we even have people like discordant couples who may still want to have other reproductive rights without condoms. So because of that, so PrEP essentially is for prevention. So it's for these people. So anybody who have a more significant, substantial risk of contracting HIV, cisgender, transgender, female sex workers, persons who inject drugs, adolescent girls and young women, they are all eligible for PrEP. So it's just for you to, so if you know that you are going to be having, maybe like female sex workers, they have more sex contacts, you are going to be having multiple sex partners, you are, and even more again, if you are living in a population, let me say in a country where the HIV epidemic or the prevalence is very high, you are also eligible for PrEP. So these are the populations that are eligible for PrEP. So it's very difficult to name a particular population because people change behaviors. Sometimes, let's say you're in Nigeria and HIV is very high in Nigeria, you may be eligible for PrEP. You may go to another country that have a very low HIV rate and you don't need PrEP again. Maybe at one point in someone's life, they have multiple sex partners, and let me say they are doing female commercial sex work. At that level, they may need PrEP, but maybe they stop doing that kind of work, they may not need PrEP anymore. People who are in prisons, closed settings, they may need PrEP. Maybe you are now released from prisons and some of all those other risks are not there, then you don't need it again. So people enter that eligibility and go out depending on their population and the situations around their HIV risk, HIV infection risk. So I can't hear you. I think you are muted.
Yes. Thank you so much. Thank you so much for giving us a solid response to that. Now, according to the Global PrEP Tracker, the total number of global PrEP initiations increased from approximately 100,000 in 2016 to over 8 million by 2024. There are myths on PrEP. What are the myths on PrEP, Mr. Ifeanyi? What are the myths on PrEP you know as someone in the field?
Come again, I didn't get that. You said the number moved from 100,000 to 2.1 million.
The number moved from 100,000 in 2016 to over 8 million by 2024. Like initiations, PrEP initiations, which is good. Yes. So now, Mr. Ifeanyi, this is your field. What myths have you come across on PrEP?
I'm not that word. What myths? What?
Myths,
I'm not getting that.
Myths. MYTHS.
Oh, myths. Oh, sorry. That's what confused me. So, sorry for my Nigerian ears. So, some of the things is number one, that PrEP is cure. It's not cure. PrEP is not cure for HIV. If you are already tested, if you're already confirmed HIV positive, PrEP can't cure HIV. So that's one of the myths, popular myths that is around PrEP. The other thing is that PrEP, some persons have said, especially for people who do cisgender, transgender, because people who undergo cisgender and transgender transformations do a whole lot of hormonal therapies. So one of the myths is that combining PrEP, it has effect on your hormonal therapy. Is also a myth. If you are within that population and you have risk of coming down with HIV, so that's that is also one of the issues with PrEP. Another thing, which for someone like me who is working in harm reduction, that happens with HIV conversation is that once we start talking about HIV prevention, everybody starts thinking about promiscuity. Why are you telling people that? Okay, for example, I do I do harm reduction for people who use drugs. So when you start, like I'm a pastor, and then so when you start talking about you are giving some persons needle and syringe so that they don't share needle and syringe and get down with HIV and hepatitis and other blood-borne infections. They tell you that you're encouraging drug use. Why will you be giving them needle and syringe? So it's the same thing with PrEP. When you say take PrEP, someone is saying you are promoting. Why are you just saying that you are trying, instead of you to use the fear of it contracting HIV to scare someone from going to sex work, you are saying take PrEP, and PrEP is going to prevent you from HIV, from coming down with HIV, and so you can continue your sex work. Let me even tell you something. Do you know that this recently, when Donald Trump came into into the United States government, the 2025 funding cuts that were experienced in the HIV space?
Yes.
One of the programs that currently, as I'm talking to you now, I'm going to actually say this. One of the challenges we had was that PrEP was one of the programs that was stopped.
Interesting.
One of the programs, HIV prevention had the highest funding cuts, and PrEP was one of the major places where HIV where PrEP program was cut. So the argument was this, that over the years there were some places in the US, in the USAID budget, where we are seeing $50 million for grant aid for condoms. People were saying why. So the argument is that as long as you keep on giving these people means to prevent coming down with this disease, they are not going to stop. That was the argument. So you are encouraging promiscuity, you are encouraging people to continue and taking risky behaviors. So PrEP was stopped, that we cannot be paying for people not changing their behavior. Instead of telling them stop sex work, stop using drugs, we are now providing a means for them to continue without having consequence, what the so-called consequence. So one of the myths is that PrEP encourages promiscuity, encourages people to continue using drugs, it encourages those risky behavior. So that's one of the challenges that we have, one of the myths that we have in PrEP. Another one is that some persons think that PrEP is for people who are only HIV positive. So if you are not HIV positive, why are you going to say they should give you drugs? Yes, why are you saying they should? In fact, stigma is one of the reasons why we moved from the oral, because PrEP currently, the old regimen, oral PrEP is every day you take one pill, every day you take pills, every day.
Okay.
But with Lenacapavir now, you take an injection, and I think you take 2 doses of an injection, and then after that, you are okay for 6 months. Because stigma, people don't want to
people, if somebody is going to an HIV drop-in center to pick any medication, the person is positive. So these are some of the myths around PrEP. So that it's not effective, that it affects your hormonal therapy, that it's just for people who have who are positive. And one of the big that one is connected to stigma. And the second one I want to mention, that one I spent most time talking about, promiscuity and drug use, is also directed to stigma. It's also related to stigma. So those myths are myths that are actually driven by stigma. Those are some of the myths that are around PrEP. And some persons also think that it's just for men who sleep with men too, because evidence has shown that there's a there's more chance of people coming down with HIV infection. Anal sex actually costs more. The risk is higher than vaginal sex. So because of that framing, it's like anytime someone who has anal sex with someone who is infected with HIV, the tendencies, I can't get the statistics now, but the tendency of the non-HIV person becoming positive is very high, because there's more bruises, there is more potential for blood exchange, the virus can move than, in fact, the research has even shown that if an HIV positive person in vaginal sex, there's a chance that in HIV positive and HIV negative person can have sex, and if it's not that rough, it can end without transmission. But for MSM, it's almost as if there is a certainty that there will be. So because of that, some persons feel this prevention thing is always pushed towards this population. It's for this population. So that's one of the myths around PrEP. Thank you.
Thank you so much for clearing these myths around PrEP. We know for every drug, for every disease, there are always myths around them. And I believe with this, we'll increase more PrEP initiations across the world. So, Mr. Ifeanyi, when I was reading your paper, I came across priority populations. Why are they termed priority population? Who are the priority population? Why are they termed priority?
Yeah.
Why another name, like, okay, special group of people or people living with, instead of priority population?
Yeah. So that paper, I'm going to explain from that paper, and I'm going to explain from the HIV terminologies, the species. But before I wanted to say, one of the things I wanted to say is regarding the last question you asked, is that misinformation and disinformation is one of the major barriers to PrEP initiation. And you said something initially that 2024 to 2025, somebody tweeted that they had the highest drop in initiation. So I'm trying to point you one of those tweets to see what happened with the funding cuts. It really affected PrEP programming in 2025. Now, when we did this paper, we submitted this paper as key populations, and it went for peer review. So when it came back for peer review, the populations we selected to focus our review on were not the population that the WHO defines as key populations. So the WHO defines key populations. They included people like those who are in closed settings. That is, people who are in the prisons, because there's a very high rate of men sleeping with men in prisons. People are bullied. People are that kind of violence. Yes, it happens the tendencies are very high in prisons. And people living in closed settings like prisons do not usually many times have access to healthcare, especially in sub-Saharan Africa, where we have the highest burden. So you have things like female warders having relationship with inmates. You have a whole lot of things happening in closed settings. Then we have this other. Then we also have this other key population that many people don't know and don't talk about. And I think maybe because of this conversation, I'm going to look into doing a paper on this population. Long distance truck drivers.
Okay.
Yeah. So let me come to Nigeria. Somebody traveling from, let's say, moving beans from Portiscombe in Yobe State to Lagos. The person is going to drive the entire Northeast, drive through major parts of the North Central, drive through
Yes.
some parts of the Southwest. So you see, that's why you see in that journey, they have places where they stop through the night, because that journey takes, they don't run like speed cars. So that journey takes days. So in the communities where they park these trucks, they meet with people. Many of them have girlfriends in these communities where they park. So they are also a key population. Yes, they are also a key population. So
Okay.
because key populations are defined around behaviors, risky behaviors. So when someone is traveling, someone has a wife, the person is already sexually exposed, and the person is traveling that long distance. Some of them stop somewhere, they get into either female sex workers, they just get into brothels. Some of them have people in local communities that they give money to, so they are also key populations.
Okay.
So we have to now look at the scope of our paper and the populations we want to focus on. So we change the word key there, to priority, that us now we are prioritizing these populations in our review. So we did people who use drugs. In the WHO definition, people who use drugs are not key populations. A subset of people who use drugs called people who inject drugs. So we have P-woods and we have P-weeds. So people who inject drugs. So the injection. So somebody would just, let me say, take tramadol, take cocaine, take methamphetamine. That person is not an injecting drug user. You can take those drugs without injecting. Then we now have people who do, I think we have people who now do fentanyl, some of all these injectables that inject drugs. So in the Nigerian context, we used to have colos, we used to have all the ones that they take, then we have the ones that they inject. So now, someone injecting, so the issue with injecting drug users is that because of these people live underground, because of the criminalization of drug use in most countries, stigma, anybody who is using drug is useless. What many times they do is that they stay in bunks, where we call bunks, they hide. So because they are hiding, they can be 10. One person will inject and take the needle and give to the next person to inject.
Yeah.
Do you know that because of, thank God you're a doctor, withdrawal symptoms, addiction, someone may not even find the drug to inject and ask an other person. So because my major work in HIV is with this population, they will get, you say, you have injected drugs now, and the drugs is really high, and there's no any other drug to inject, and somebody is telling me to draw out my own blood, because it has the drugs in it, and give him to inject that blood
so that he gets
so that he gets the drug that is in circulation. So you see, HIV, all bloodborne diseases can be transmitted like this, right? So we chose people who use drugs, because now, among the ones who don't inject, there is overlapping behaviors. People who use drugs are most likely to have sex without condoms. Women, with the project I work in majorly, is even for women who use drugs. So women who use drugs can have sex under the influence of drugs. Some of them, I had a focus group discussion one time, and someone was saying something that they prefer to spend their nights in any random guy's house. Some of these women will use drugs than to just stay on the street and get harmed. Are you seeing how the behavior overlaps? Sometimes when a woman is addicted to drug use and she doesn't have money to get that drug use, if she sees a man that wants to have sex with her and give her some money, she is willing, on the man's condition. So when we advocate, we create awareness, always use condoms. Some of them, under that economic pressure, don't care if the person that can supply that money doesn't have condom, as long as that person can give me money to buy drugs. So because of how overlapping these risky behaviors work, we selected some populations. So we did transgender, people who use drug, female sex workers. We also included adolescent girls and young women, because adolescent girls and young women fall within this bracket of incentivizing them with money, the rest of them. So they may not call themselves female sex workers, but they need school fees. They need somebody to spice them something. They need somebody to get them, and they fall into some of it. So poverty and all the rest of these things that happen in the community. So we selected those populations because they are priority. But then the primary term that is being used are key populations, populations with increased risky behaviors of coming down with HIV. So, but in our review, we didn't include all key populations according to WHO standards, and we also included some populations that they don't call key populations. That's why we use the word priority populations. Yeah, that's
Okay, thank you. Thank you so much for explaining that excellently. Now, what one of the things I found interesting while reading your paper was provider level stigma. And naturally, I don't understand why that should happen. But you, as a researcher, you tell me how we can erase provider level stigma in PrEP utilization.
So when we say stigma is not just PrEP. It affects PrEP initiation. People at risk don't come. I started a national study, and it was difficult for me to actually continue.
Okay.
Yes, because of it's not funded. So I only got about 175 responses. I'm thinking of starting again to see if I can be that lucky. But I know if I had some funding, I could incentivize people to complete my survey. So I wanted to know what do young healthcare professionals, those that have internship, 600 level, intense health officers, those working that have 0 to 5 years work experience, what do they know about HIV-related stigma? What do they know about HIV-related stigma? So I wanted to probe. I'm a medical laboratory scientist, you're a doctor. I schooled in Nigeria. I don't know if you schooled in Nigeria, but I wanted to go back to the curriculum. I knew that when I was in school, nobody mentioned anything like that, right? So I wanted to go, what is in the curriculum? Have you ever been taught? Have you been trained? Have you seen in your health facility a health worker treating an HIV person differently from others? Some of those questions I wanted to get from Young Health. I got some data, but it's not sufficient to pull for a national survey. I wanted a cross-sectional national survey. If I can get every teaching hospital, people responding, every secondary healthcare, so it will need good funding to just see what's the stigma like. So I may eventually go on to just do it as a focal, as I do a qualitative study, so to see if I can get small groups and instead of a survey. And you get to see that there is provider stigma. You hear people saying things. I've had conversations with women who use drugs in focal discussion, and a nurse during delivery is telling you, push. Don't be me tell you go carry belly. This belly. You know, the way so the stigma is a perception thing.
Yeah.
And so when healthcare workers are not trained not to stigmatize these populations won't come to the healthcare facilities to take PrEP. And that's the reason why donors now started funding community-based organizations. We started having things like drop-in centers. We started having things like safe spaces.
Yeah.
Where these populations can go. We started having things like peer-to-peer. We started having things like peer-to-peer community solutions. So we take all the prep and give it to, let me say, one particular female sex worker. That female sex worker now become a meeting point for the rest.
Okay.
Because they feel when they come out to the hospital, people begin to call them things like ashawo, prostitute, so they prefer not to come to health facilities. So to take prep to them, we need to now begin to do mobile outreach, looking for drug users hotspots, female sex workers hotspots, opening drop-in centers, safe space, so that they could come to where they feel safe to come and take those medications and go. So that's what provider level stigma generally do to these populations. So many times we encourage people to like try your best and let's train healthcare workers on gender sensitivity, harm reduction.
Exactly.
You understand?
Exactly.
On key populations, on HIV prevention. Let's promote, I think you must be hearing what we call person-centered care. Forget about why the person came down with HIV. Think about the person, the rights of this person, the health of this person. Those are some of the things we are talking about. Accountability, there should be opportunities for people to report stigma. Many facilities don't have. There should be, and then when we are training healthcare workers, we always do this in my organization. Sometimes we bring the community member, these female sales workers. I'm telling you that we brought them to talk in meetings with people coming from the Senate. We brought them to talk in meetings because we want you to see these people, that they are human beings. They are not criminals. That somebody is a female sex worker does not mean that the person doesn't have human rights. We bring them together with police, law enforcement agents, so to reduce stigma. Say, these persons you are profiling, you are sitting with this person in the same room now. This person is asking you questions, you are conversing with them. This person is a person like you, but has a problem. So these are some of the things. So when we say provider, we're talking about even the people. Like when I started, like I said, I'm a pastor. I have a background in Christian Pentecostals. I'm a deeper life person. So when I came into harm reduction space for the first time, it was strange. Honestly, Dr. Azeezat, it was strange.
What is happening in the world?
I was the M&E officer, so they said, you go to the community, you meet these people, and then you give them condoms. You teach them that they should use condoms. So I'm thinking, I'm supposed to be preaching the gospel to these people. So I'm supposed to be preaching. I'm supposed to be saying, repent, turn away. Why are you doing this? And now I'm walking. So it also took me being trained, being sensitized that this is public health. I had to learn and learn. So you cannot just say people should just be caring for them, that because of someone is a medical doctor, the person should not have any bias, or a female sex worker, somebody with rings in their nose, dreadlocks. And of course, you have to train this pet. You have to train. I don't know you understand what I'm trying to say. So what we are saying is that provider-driven stigmatization, all of those things exist, and they must come into our training curriculum. They must come into the conversation. We must sensitize people that these persons are not criminals. These persons, they are not, someone coming for PrEP does not mean the person is already HIV positive. That someone coming for PrEP does not mean that the person has maybe one gender identity that you don't know. Person-centered care. This person needs this to prevent them from coming down with disease. Just focus on that and take care of that. That's the conversation we are doing with that provider-based care, person-centered care, and provider-driven stigma. Yeah.
Thank you so much for that. You've explained so much. One thing is, people tend not to look at provider level stigma. They tend to look at stigma from the community, and provider level stigma is a thing and it exists, and we hope to eradicate it.
Because the doctor came from the community. The nurse came from churches. They came from
heaven.
They didn't fall. So you have to train them. You have to tell them. Yeah, let's go. Thank you.
Yes. Now, As someone in the One Health space, something I keep seeing is target, agenda, target, agenda. Now, in terms of HIV, there are also targets. Now, what are the global HIV prevention targets?
Yeah, for PrEP specifically, the 2025 target, according to UNAIDS, is around 21 million. I think 21.2, 21.5, but I know 20 to 22 million. That's the initiations we would like to see at the end of 2025, which we're already in 2026, which wasn't achieved because as of 2024, it was around just 8 point something million, right? So we didn't achieve that. So for PrEP initiation, for most HIV prevention packages, the targets are not very easy to measure. And with lenacapavir now coming into the space now, there are new targets for PrEP too with lenacapavir. But the general thing is that by 2030, we should achieve our 95, 95, 95 targets. 95% of every possible person at risk is tested. 95% of every confirmed positive HIV person is on medication. And 95% of that population is virally suppressed. So that's the target. That is how we can prevent HIV. That is how we can end the epidemic. That is how it's now an epidemic before it was a pandemic. That is how we can end it. If everybody knows their status, HIV status, fine and good. So nobody is just getting sick somewhere and we don't know. If everybody who is positive is on medication, fine and good. It means that nobody is dying because of HIV infection. And if
Exactly.
everybody's medication is virally suppressed, it means that nobody is transmitting HIV.
Exactly.
So those are the major targets for the HIV this thing. So reduce new infection, that is testing. Reduce new infection. That is it. New infection. Lagos, I just saw a report. They say Lagos had almost 10,000 or 6,000 new infections, and it was too much for me. Too much. If in 2026 we're having in 1 year, that's in 2025, we're having 5,000 new infection of HIV. HIV. This is HIV that we've been talking about for years. Then there's a problem. So we want to reduce new infection. And then we want to reduce people dying, people having comorbidities, tuberculosis, and the rest of them via HIV. We want to reduce people by reducing new infection. We want to reduce the potential of people who have HIV from transmitting it. So that's what we call index testing. What we do in index testing is that if we test someone for HIV infection today and the person is HIV positive, we go on to enroll the person in treatment and do the person's viral load count. If that person's viral load count is not suppressed, we come back to the person and begin to ask, did you meet with anybody in the last 2 weeks? Did you meet with anybody? So we want to test, we want to do that, text anybody that has met with that person in any way, in any risky way within that period. We tell, if you really love your boyfriend, please show us his house, give us his number, let us test him. So if people do not know their HIV status, even before they start falling sick, they must have been transmitting it to other people.
Yes.
But when they know, they can protect other people, they can use condoms, they can disclose their status to other people, and then, but when they don't know, they are just doing that. When they know, they can also tell us quickly. That's why we are testing. This is I just met with this person, or I just had a risky behavior with this person, and we quickly go in to check that person too. So sometimes when we say there's what we call post-exposure prophylaxis too, even though that's not what we are discussing, where someone within 72 hours of contacting someone. So if you we discover that you're HIV positive today and we do HIV index testing, and you show someone that you just met with the person, let me use sex, maybe by sex in the last 24 hours, that person has a chance of not coming down with HIV if that person received post-exposure prophylaxis. So that's why we're that's why we're talking about all the targets are working hand in hand to ensure that we defeat the HIV epidemic at the goals that have been set by most of the governing bodies. And then for PrEP, we are falling very short of our target. We want to see more people having PrEP. Maybe with more PrEP, we have less new infection.